From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing the review article, Pro-Renata PRN, Treatment of Postoperative Hypertension for Inpatient Surgical Patients. We are here with two of the authors, Dr. Wren and Dr. Baylee Bakkila from Stanford University, Department of Surgery. Thank you for joining us today.
Thanks. It's great to be here.
Thanks for having us.
Today, we're talking about postoperative hypertension, a condition that affects 72%, so almost 3/4 of patients during an acute care hospitalization. Now, I love starting these podcasts with why. So can you tell me a bit about the why and the need for this review article?
So this is a why driven by my pet peeve. And it goes to show you can turn a pet peeve into an article. Over the years, I really noticed that all of a sudden, patients were getting IV medications for asymptomatic hypertension. And I sort of remember, when I was a resident and somebody would be like, yeah, their blood pressure is 150. We'd be like, yeah, that's great, because what you were worried about was hypotension. And I think a lot of it became, I'm old enough that hypertension as a national state wasn't really defined and worked on as much. And all of our incoming residents for years now just have this, if you've got a blood pressure greater than 130, you're hypertensive. And it started driving, I think, a lot of attention to it. And then at some point, and I don't know when, you started seeing PRN orders. It sort of exploded, and there was actually a JAMA internal medicine article, I think in 2017, in the Less is More thing, which I love reading those articles because I think it's great. The whole concept of de-implementation and things like that is tough. And I remember it was a rant on exactly what I was talking about. And I was like, wow, it's happening in medicine too. So I kind of kept that in mind. And a year ago, I changed our hospital's order sets for this in conjunction with our medical lead. So actually at the VA now, all those standard order sets that go talk about remeasuring hypertension and all sorts of things and assessing, but I don't think it stopped behavior. So this was literally out of a years-long pet peeve.
And if I can add, from a trainee standpoint, a second-year general surgery resident here, and a lot of things we learn on the floor are just see one, do one. So you see someone else treat asymptomatic hypertension, and then you kind of learn to do that too. You take cues from the nurses around you as a trainee about what you should be doing on the floor. Even last night, I got a message from a patient's nurse saying, oh, their blood pressure is like 175/60. I don't have another PRN labetalol. Will you put one in for me? When the patient had completely no symptoms. And I think a lot of people, that just triggers an action from them.
And I think now is actually the perfect time, since we do have a lot of learners that listen to this podcast. Let's do a little bit of a definition session. So could you please review for us just a brief definition of hypertension? And then also the American Heart Association has proposed some terminology that really plays a key role in the decision-making. Maybe we should just start with that for especially our learners that are listening.
So, hypertension, broadly speaking, is elevated blood pressure. The definition of what would meet criteria for hypertension have changed over the years. And I think part of what this review gets at is that these markers should also differ in an acute inpatient setting versus managing someone's chronic hypertension or elevated blood pressure. We really hinged our review on the opinions of the American Heart Association and one of their reviews they put out last year. And the proposed terminology they had in that piece were that if you had systolic blood pressure greater than 180 over diastolic blood pressure greater than 110/120, with evidence of new or worsening end organ damage, that would be hypertensive emergency. So a reason to acutely bring down someone's blood pressure because it's causing a negative downstream effect on organ function. They then market their next bucket as asymptomatic, markedly elevated inpatient blood pressure. So it's those same thresholds, 180 for the systolic, 110 to 190 for the diastolic, but they have no symptoms or evidence of end organ damage. So it's just a marker. It's just something we're seeing on the blood pressure cuff, but no correlate to a clinical finding for the patient. And then the last one is asymptomatic elevated inpatient blood pressure. And these are kind of more the thresholds they use in the outpatient clinic and when they're thinking about oral antihypertensives in the outpatient setting. So this would be a systolic blood pressure greater than 130 over diastolic of 80 without evidence of new or worsening target end organ damage.
I also think it's important for people to understand that the old-fashioned blood pressure, right, where you actually had to put the I'm not even sure I can say it anymore, sphygmomanometer on somebody and auscultate the pressures, those are actually much more accurate. The automatic ones that are just ubiquitous are so sensitive to size of the cuff, where it's placed, and actually the machine itself. And the range on these could be plus or minus. That's the problem. You don't really know. So and I think as you begin to take stock in blood pressure measurements, if you think about it as an outpatient, you don't even treat somebody on a single measurement, right? They actually have to show sustained measurements. But yet all of a sudden in the hospital, you get one measurement at a point in time when a patient is post-op, they may have pain, all sorts of other issues. And all of a sudden, boom, a page goes out with an expectation for an order. Because it's not just physicians, it's actually the nurses now also. And I don't know where that kind of inculcation started, that everything had to be treated.
But I think you articulate that so well in this article because for our listeners out there, the error range that's quoted in the paper is anywhere from -14 to +33. That is a range of 47 millimeters of mercury. That's huge. And I think you really go through that well, that there are cuff size issues, measurement technique, environmental factors, pain. You wake anybody up at 2 o'clock in the morning and try and take their blood pressure, they might be a little irritated at you. And so I think it's so well articulated in the article that goes into, again, strengthening the idea behind this, that maybe we shouldn't just be running off to give medications for people. And we're going to actually walk through the algorithm here in a second. But you mentioned this patient that got hydralazine. I think is another real point in the article where there can be real consequences when we're treating asymptomatic hypertension, especially if it's situational, where they aren't really hypertensive, where maybe it's falsely elevated just because they have a little bit of pain at the moment. It's not a false elevation per se, but it's not something consistent. It's momentarily elevated, but we're going to give them a drug that's going to last for hours. So can you talk to us a little bit or outline real consequences that can happen to our patients?
If you look at especially the most common agent that I've seen given is hydralazine. And if you look at the literature, it's about 60 to 70% is given hydralazine, which I actually found really interesting because it wasn't until we were doing this report, we found that statement literally saying, don't use hydralazine in this setting because such rapid onset, it drops your pressure so much and it lasts for hours. And they actually suggested labetalol, which I just heard you say, Dr. Bakkila, that you guys gave labetalol. So somebody was reading the article in advance. But if you then drop somebody's pressure too low, you can get into potential AKIs and other damage. So I was relating the story of a colleague who was in the hospital for a procedure and had a single measurement, of 180. They called a hospitalist. Hospitalist has never seen this patient. This patient is unbelievably robustly fit, all sorts of things. Gave them hydralazine within a fairly short period of time. Blood pressure is now 80. The individual feels horrible. calls the nursing staff and is demanding to have the bed put in Trent-Dellenberg and wants a full list because, of course, they're a surgeon and they, it can absolutely have an effect. And I think the most important thing is when it's been looked at and multiple retrospective cohorts of both medical and surgical patients, you actually can show harm done if blood pressure lowering regimens are changed or used in the hospital. So, it's observational data. It is what it is. So you can't imply causation, but there's certainly correlation.
Dr. Bakkila, this is perfect for you as a resident because I want to walk through. Let's talk a little bit about that phone call that you got. Let's say, one of my residents gets a phone call tonight, right? With a patient admitted to the floor. They're calling you for an elevated blood pressure. Now, this patient, does not have any surgery-specific blood pressure parameters, but their blood pressure is 150/90. Using your algorithm, can you walk us through really the next steps?
Yeah, absolutely. So the first is to just assess the patient, like you should whenever you get a page from a nurse, and see if there's anything driving this. So a few things we mentioned, like pain. Another thing that could happen is, we're doing fully removal void trials. Maybe they're retaining after surgery. Maybe they've gotten like a bronchodilator recently, or you can look at their resuscitation from the operating room. Are they hypervolemic? You can check their outpatient meds and see if there's any like antihypertensive withdrawal going on, if it's been a while since they've had their home meds. Really assessing the patient globally and seeing if there's anything else that's causing them to have this elevated blood pressure. The next part of the algorithm, like you mentioned, is there's no surgery-specific parameters. So no impulse controls needed for like a vascular operation, cardiac. Obviously, that should take precedence. And then you should look at their blood pressure numbers. And if they meet these criteria that we described for having an elevated inpatient blood pressure, you need to make sure there's no evidence of end organ damage. Things you would be looking for, like encephalopathy, evidence of a CVA or an MI. And if someone was having chest pain, you could check labs and look if they're having an acute kidney injury and assess, again, if any of these end organs are feeling the heat of the high blood pressure. And if that's not the case, then what the American Heart Association and what our review paper says is that you should let them ride.
And I think for a blood pressure of 150, I wouldn't even do any of that. I would not go to the bedside and assess. I think that's when you're getting up in the 180s. And the other thing that I really appreciate now that we have electronic medical records is most of these patients have some sort of history with us. You can pull up their prior measurements. What worries me is when you have somebody coming in that consistently as an outpatient and everything has pressures in 170s. And all of a sudden we're trying to get this person to like, oh my God, their pressure's 170. And now, especially for they're older, they probably got stiffer vessels. And now we have some sort of magic goal of 130 because that's a definition of hypertension. That, I think, is an opportunity for real harm to be done. I think separating in your mind, you are not fixing chronic hypertension as an inpatient. That's an
Right.
outpatient thing. That's for their primary care doctor. Half the time their meds have been held because of the anesthesiologist doesn't want them to get X med, and then we don't necessarily order it post-op, which we should. Good data to support that. And it's sort of one of those things, what problem are you trying to fix? Ask yourself. If they're asymptomatic, what are we doing? But I think the hardest thing is, this is where I feel bad for the residents. If you don't do something, it's like you get the black mark. Then they're going to call you back, and then they're going to document in the chart. I called Dr. Bakkila for a blood pressure of 183, no intervention.
You made that point well in the article that there needs to be systematic changes so that we're not putting ourselves or our trainees in this situation. And we're also not training our nurses and nursing staff to get into the situation where then now all of a sudden the residents feel like they have to write something because if they don't write for something, they get dinged. Well, this is such a great article with such real clinical guidance for a very common occurrence in our post-operative patients. Thank you both so much for joining us today.
Thank you. Thank you for picking our paper.
Thank you.
The article is such a good clinical article that I really encourage everyone, especially our trainees and learners who are listening. Please, you've got to take a look at this. paper. You got to take a look at this algorithm. It's so great. Dr. Wren and Dr. Bakkila, thank you both so much for joining me today to discuss your article, Prore Nata, PRN, Treatment of Postoperative Hypertension for Inpatient Surgical Patients. Our listeners can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Stuffins at the JAMA Network. Thanks for listening. Have a great day, everybody.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.